Well, this is an exciting day for me, guys, because I have an opportunity to interview someone who I've met and interviewed many times, but virtually. This is my first time meeting Dr. Katie Boston-Leary in person. Thank you for being on today.
Thank you for having me, and it's my. I'm really excited. I was excited to see you today. I got to say, it's been long overdue.
Absolutely. Yeah, absolutely. And so for those of you who may not know, she is a national speaker. She's a trainer. She's an author. She's a healthcare executive. Many years as a chief nursing officer, now doing a lot of work with other organizations. And so really looking forward to getting your perspective.
Sure, let's do it. Let's do it.
Okay. All right, so some of the things I've been hearing recently that I wanted to talk about, number one, is being just the overall climate of things maybe appearing to be improving when it comes to nurse retention and things of that nature, but there still seems to be an issue or problem there.
Yeah.
And so what's your overall view? Is it a problem, or is it something that's kind of working itself out?
Yeah, retention is still an issue, and I appreciate you starting there because that's where a lot of the work needs to happen in addition to the recruitment piece. Because if you just focus mostly on recruitment and you still have the bottom of the bag and you're losing people, it's endless work, right? So we all want to do meaningful work and be more additive in what we do. But retention is still an issue. I think a lot of it has to do with the fact that many nurses practice in unhealthy work environments. What does that mean? It really is about the fact that there are so many burdens that nurses have to carry for what they do, physically, emotionally, psychologically, even morally, which impacts their willingness to stay. Healthcare is also very hierarchical and bureaucratic, which is also burdensome and oppressive to a lot of nurses. There's a lot that's happening in society that hasn't caught up to nursing yet in terms of giving nurses more life-work balance. For example, they see people in their family or their friends that are being able to work have hybrid roles or remotely, and they can't. And then also care is very complex that we have to provide. Patients are sicker, the demands are a lot higher, the margins are tighter. So all those things culminate in this environment that feels very industrial for nurses. And it's not moving towards what the new wave, a new age worker wants in this information age. So that's what we're contending with right now.
I thought one thing you said was quite interesting today, and that is the moral burden. Okay,
Yes.
I want to drill down. What does that mean? Give me an example of a moral burden that the nurse would have.
Sure. One of the surveys that we did at the American Nurses Association with the foundation is one of the major issues that nurses face every day is that they're unable to provide their patients the care that they deserve. They see themselves in their patients, and at the end of a long shift, because of all that's required of a nurse, it's almost impossible to meet all the needs that have to be met. So because of that, you leave with this thinking that, oh, I forgot to do this, oh, I could have done that. And the biggest issue really is, I wish I was able to spend more time with my patients to get to know them. And that's unfortunately more the case than not, because somehow we've unintentionally created a care delivery system where nurses spend less time with their patients. And spending time with your patients is really where the joy is in nursing. And we're all consumers too, we see it. Even though we're also care providers, we see what it looks like when we're on the other side. When we're in healthcare settings for ourselves or our loved ones, we see that the eye contact that we desire is more tilted towards the computers and paperwork. And that's where you see a lot of the moral burden come out, where I wish I could have done more. My patients deserve more. I'm better than this, but right. I'm not able to do what I'm supposed to do.
Wow, that's interesting. And one of the things I have heard quite a bit is an emphasis over the past few years on staffing ratios. And then I've also heard, okay, well, it's not about the staffing ratios as it is resources in terms of nurses working at the top of their license because they're having to do things that maybe some of the support staff could do. So what do you think it is in terms of what should organizations be focusing more on? Is it the staffing ratio itself? Is it providing more resources for the nurses to work at the top of their license? Is it something else? What are your thoughts on that?
So you're touching on one of the touchiest, more polarizing topics in nursing, ratios. And actually, I'll say in the acute care setting. So I'm going to try to unpack this because I work for the American Nurses Association and we support ratios. But when we say that, we're not saying that's a be-all, end-all because we do believe that it is foundational. No matter who you are and what you do, if you happen to be a nurse at any point in your life or give care at any point in your life and you're given an assignment, of course you're going to want to know how many patients you have compared to the next guy and what that means in terms of being able to provide adequate care. And I do believe that there are a lot of good actors that are doing the right thing, that are providing very safe, appropriate staffing in terms of numbers for nurses. But there are also bad actors that are paying more attention to the margins versus the mission, which is leaving nurses saying, why this is not sustainable. In the middle, you also have situations where, let's say, you budget appropriately, you hire and fill all your gaps, which is hard to believe these days, but you fill all your vacancies, you have all of your people, and then you get a call out or two. That means that nurses have to take more on, which they tend to do anyway. But the conversations and discussions around the whys and the plan Bs and contingency plans for when these things happen also needs to be in place as well. And do what you can to address it, but most importantly, make sure nurses know that you've done your best. So now they can say, okay, I'm taking a little bit more on today. It's okay for today, maybe tomorrow, but what's the long-term plan? So the discussion around ratios is that that's not the be-all, end-all, ever.
Okay.
Should never be. It's about that being, if you think about it in a building blocks kind of way, that's foundational. On top of that, think about complexity, acuity, geographical distribution, like you don't want patients at two ends of the hall, right? Mm-hmm. All those different pieces, the burdens also that comes with, and I'm using burdens very loosely here, with care intensity, how much a patient requires, how much a family requires, all those different pieces. The safety components, if you put all those pieces together, that's how you build this. And then what you wrap around it is the technology to help reduce the burdens for nurses. We should be incorporating technology, or integrating technology that helps reduce work burden. And we have to also think about technology to improve our reach. So that's why virtual care is very, very popular these days. A lot of institutions have put it in place. And that's where you can have another layer of support and surveillance for patients so that there is that nurse that's remote, that's connecting with that patient. This is not new because we've had telehealth and tele-ICUs for years, but we're seeing that being implemented in a broader way. So when you really think about all the different components for delivering appropriate and safe care and staffing, it's really about building it from that in a stacked kind of way versus just looking at one dimension, which is not where we are. Right.
Now you mentioned the telehealth and the virtual. I'm curious, is there a way that perhaps organizations could, or what should that look like, I guess is what I'm trying to say. What should it look like in terms to maximize it? Because I'm thinking, yeah, it's one thing to try and consult with a patient who's already at home, maybe they're back at home, and the nurse is communicating with them, or perhaps they're somewhere off, I guess further away on the unit, maybe the telemetry unit. But is that the extent of where it should be, or is there more that could be done? Perhaps, is there more things that could be done in virtual care that aren't being done now that you can see?
Oh, absolutely. I think it's been isolated to certain specialties, and there's a desire and a call for it to be implemented more widely. And we at ANA have started to have, we've actually pulled together a panel to talk about that. If you think about, and we have this diverse group of nurse leaders from around the country in school nursing. I mean, think about the benefits there, knowing that we have so many gaps in school nursing. And kids are a lot sicker these days. We have school nurses that are sharing about how acute the care is there, right? So school nursing, correctional nursing, rural areas, right, which is clearly where we saw a lot of benefit with during the pandemic. In addition to in these buildings where we're delivering acute care, right, there's opportunity there as well. I remember years ago there was a proposal, and there's this, and I believe that it was a city in Minnesota, where they actually used telehealth to prevent unnecessary admissions and walk-ins to the emergency room, where the EMTs are connecting with physicians when they're called to see patients in their homes, and working with physicians and practitioners in the emergency room to determine whether these patients could need to be brought to the emergency room or they could wait till the next morning. So there's so much potential for it. And then you add on AI, so much more. So we need to be open to that and not reject it, because the future is now, right? And I deliberately said virtual care versus virtual nursing, because virtual care delivery is not a nursing thing, it's an everybody thing. And I do think that if institutions start thinking of it that way in terms of the future of care delivery, it will be more widely embraced and invested in.
One of the things I thought was pretty impactful that you mentioned in the presentation that you had today was changing the H in the hospital for something else. So
to the W.
Yeah.
Yeah. I think hospitals are beacons in communities that they sit in. And it's important for us to, there's always been this discussion around the healthcare system is a sick care system. And if we start turning these institutions, these brick and mortars, into wellness centers for preventative care, and not just from a physiological maintenance piece, right? There are institutions that, because they say you build your hospital from the outside in versus the inside out these days. So you think about what else societies, certain aspects and pieces of society needs, what community needs, and build that into those hospitals where it is a beacon for all those different pieces about life for people to be able to live fuller, healthier, and lives where they feel that they can flourish. So the H, I think, is more set up where it's this institution where, unfortunately, a lot of people fear it. If I come in here, am I going to get safe care? Am I going to make it out? And we have those fears anyway. I mean, think about how we feel going to the dentist, right?
Right.
But I do think that there's more, if we can turn the tide, and I think the pandemic set us back, but if we can turn the tide back to preventative health, right, and provide the services those community needs. Every community has a community health assessment that's done by the community health department every few years. That is a driver for what hospitals should set up to support that community.
Yeah, so that brings me to another question. The whole thought process, to me, behind a hospital has been to centralize a lot of the care. And so that was seen to be intentional. But I do see healthcare organizations, even hospital systems, are starting to build more facilities out in the communities themselves. Do you feel like there's more work that could be done to make it more a part, like embedded into the community, or is it still going to be the situation where you're going to have these very large facilities where they're just centralizing all of the care? I wanted to get your take on that. Just what are you guys seeing?
Yeah, and it doesn't have to be the hospital building different centers here and there around the community. It's the relationships. Someone mentioned recently that I learned about, collaboration is a competitive edge for any organization, right? So it is the barbershop down the street what's that relationship between the hospital and that barbershop to make sure people in those spaces are being cared for appropriately.
I never would have thought of that.
Right? It is the laundromat and what can be set up there, right? For people that are waiting for their laundry to get done, what screenings we can do there. Like, there are all these pieces and places where people gather, where those are the offshoots for how we can continue to address care in those communities. Because one thing that I've realized more and more recently, and I'm still doing some research on this, a lot of communities where zip codes where hospitals sit, people are not necessarily, you think automatically that since the zip code is where people live, is where the hospital is, they're automatically healthy because they're right there.
Right.
No. As a matter of fact, in Philadelphia, the zip code near the Liberty Bell is where people are living longer lives. There's a net difference of almost 12 to 14 years for life expectancy between where the Liberty Bell is and where the hospital is in Philadelphia. One of the hospitals, anyway. I'm not going to name it.
So why is that the case? Why is it so?
But it just means that just because you're there doesn't mean they'll come. And the offshoots and the relationships in those communities need to be improved, right? For there to be more outreach, for there to be more engagement, for there to be more work in health literacy, because health literacy is a major issue for us as well. So if hospitals focus more on, let's start under our feet, like, it doesn't make sense for these zip codes that we're in, zip code that we're in, people are living shorter lives compared to the ones where people are richer.
It's counterintuitive.
Exactly. So that's a major place to start to improve outcomes.
What could even a hospital do, though, to start that? What's a good starting place?
Well, remember during the pandemic when the vaccines came out and we focused on trusted messengers because there was a lack of trust in the medical, because there's history. And we had to shed the thinking that because we have a white coat, we're automatically trusted and believed, right? History has long arms, right? So we found that with trusted messengers, it was not us. It was not the nurses necessarily or the physicians. Maybe in some cases, yes, because if you live in those communities, you will be trusted more. But there are leaders in those communities that could also help with these efforts, that can help with outreach. They could say, the church is having, needs a community health day. How about we host it? That type of thing. Or do some tracking and care coordination with some people in those institutions that people tend to gather in to help with improving outcomes. Improving lives touched is very important.
That makes sense.
And continuing the care is very important. And I think if we start doing that, and public health has had this down for years. They do geomapping, right, in terms of where the hot spots are in terms of certain disabilities and disorders.
Right.
Hospitals can partner with health departments in doing that too, because health departments can't do it alone.
And as you're going through this mentally, you made me think of the different community centers, the different parks.
Yeah.
The schools.
The Y, right? Places like that. And some institutions are doing this. But we need to step out of making this a project. And something that this one department, maybe case management does, right? It needs to be this wraparound service that we provide. And the investment needs to be there more so than ever before, because of all that we continue to see in terms of health disparities. It is not getting better. Right.
Okay, now speaking of that, disparities, I know you've done a lot of work in that area, so I would like to talk about that. Is that improving with the disparities in healthcare? And if not, what are some of those areas where there are more disparities that are kind of uncovering themselves as you do more research?
It's hard to track. I would say that there's more awareness of it. And there's more of a reckoning with it, because in the past there was a belief that these folks that are continuing to cycle through hospitals after their discharge are non-compliant. They are high utilizers. That was the label, right? now I think the eyes are being opened, the scales are being pulled off eyeballs in terms of, well, maybe not necessarily so, right? These folks are living in communities where they don't have a lot of good food options. They don't have the necessities that we all tend to enjoy in terms of living, right? Just generally, do they have air? Do they have heat in the wintertime? Do they have clean water? So I think there's more of an awareness than anything, because the lagging indicator, right, in terms of outcomes, it's so lagging. It's hard to know that we are making a difference. And there are organizations that are still trying to figure out what it's going to look like to really have an impact. There's a lot of desire and research and some work, but I do think that the investments to really turn the tide are lacking.
What could be done to turn the tide?
I believe that there needs to be more public-private partnerships with organizations and institutions that are in this space. And we're seeing grants and everything like that, but think about how powerful it would be if, Hospital A says, we want to really get into this space and deal with it. And I'm going to contact the owner of this grocery store that's a major hub, right, in this community, and what that could look like, right? So, and maybe even that owner of that grocery store would make some, if not financial investments directly, but at least some ownership investments, right? Like, we both own this, we're going to do this together, and this is how we're gonna do it. Like those types of unlikely partnering, that's what needs to happen. We need to partner like we've never done it before.
I wonder why hasn't that already been done? What's holding organizations back?
Well, I think there's some movement that's happening, but I do think that because of a lot of the demand that we're dealing with, particularly in the acute care setting where that has not waned, because it's a teeter-totter, right? There was a hope that we'll reduce a lot of emergency room overcrowding, emergency department overcrowding, and then we can start to have some more focus on preventative health. We're still seeing so much emergency department overcrowding, right? And then we have all these labor issues. So then the question is, who's going to do all that? We know there's a problem, but who's going to do it? We can't hire nurses, hard to get physicians. All these comes at a cost. So who's going to pay for it? So that's why we have to think about some of these other partnerships in the private sector that can help with these pieces. So not the for-profit sector needs to help with these pieces, the investments, the ability to even jointly hire positions, right, that would focus on this.
So if you had a way, an ability to just kind of flick your wrist and it fixes one of the major problems you're seeing within healthcare, and you only had a choice of picking one, which one would that be?
Oof. So say that again.
You talked about disparities. You talked about more community partnerships or outreach. We talked about setting up, even little extensions, I guess, of care in those different areas. So many different things have covered. If you had one thing that you could just say, boom, this is...
That would be the high impact. It would be the partnerships, clearly. Okay. I really think that is the way to go. And it's also an opportunity for hospitals to partner as well. Because it's, for years in my time anyway, it was taboo to call the hospital down the street to say, hey, let's do something together. And years ago, I remember I had a hospital, a children's hospital, when I was a chief nurse in Maryland, and right across, which was about 20 minutes away, there was a children's hospital that was, I was their training ground. Like, I'll train all the nurses, and then as soon as that hospital has an opening, they'll go over there. And it's not because of anything I wasn't doing. Because now, of course, there's always a lot more to be desired, but I knew that they offered something that I couldn't. I had a little pediatric unit. This is a major mecca of pediatric care. So, of course, nurses will want to go there because they want to be able to expand on their skills. So out of desperation, I called the chief nursing officer over there and I said, we need a partner. And I didn't even know what to say. I didn't expect her to answer the phone, but I just said, we need a partner. And she said, I'm intrigued. And that was my opening.
Wow.
So I took the time between then and when we met, was scheduled to meet, to really start plotting out what I was going to say. And I didn't ask permission, which I should have, but I was going to proceed until apprehended. And I called her. So we had our call and I said, yeah, I would like for you to brand my pediatric unit, employ my nurses, and I'll just provide you the supplies and the support resources. I want to set this up as under new management with your branding on it. Right. And it was a trusted brand in our community. And we will always transfer our pediatric patients there whenever we can figure out what was wrong. But that created unnecessary havoc in the lives of these parents because, you know how it feels. And a lot of them didn't have transportation, you know. So, so we did. She was open to it. We put together a proposal. We both shared it with our executive leaders. They were a bit annoyed at us because they felt that this doesn't usually start with nurses. It's usually is initiated by the COO or the CEO. But they gave us, side eyes, and they said, keep moving and keep us posted. And we did it. We launched.
That's awesome.
We reopened the unit. We had a community event where people came and did a ribbon cutting. We were able to reduce transfers out of the emergency room. We were able to provide care. It reduced my turnover significantly, kept my nurses whole. Those are the types of relationships and partnerships we need to form.
Right. That's amazing. Okay. So just to kind of wrap this up, if there's something that you would like to advise healthcare organizations that are watching this to do, because we've talked about a lot of things. I know you said partnerships is probably the main thing. Mm-hmm. What is that first step they could take? Like, what's that first meeting, that first phone call? What should that look like to start in that direction?
I think, there are hospitals that are doing this already, but it's really about disruption, like intentional disruption. And even setting up a meeting with a lot of stakeholders within and outside the institution, community leaders and stuff, and just say, what should we do that we've not done yet to address this issue? Like, just ask that question. That will open up this brainstorming, work on prioritizing what could have high impact, and maybe your low-hanging fruit, your high-impact, low-difficulty type of items. Mm-hmm. Get those done, measure it, and just keep moving. And make it everybody's business, right? It's not just for certain people in certain departments. It's everyone's. Like, every nurse working in every institution should care about, where am I discharging you to?
Right.
What home are you going to? Does it have electricity? Does it have, where do you get your food? Right? And the thing is, I know it's hard because there's, as I mentioned in my talk, nurses have to do so much in a short period of time. Yeah. But that's where leadership comes in. We need to free nurses up so they can have these conversations. That's what nursing was for years. Mm-hmm. And we need to get back to that. It's really about that holistic care, that whole person piece.
Well, I really appreciated watching your presentation today. And if any of you who are watching, if you ever have an opportunity to watch and get a chance to watch one of Katie Boston-Leary's presentations, I highly recommend that you do that. What's a good way for them to kind of see what's going on with you? If they have more questions and they want to contact you directly, what's a good way to do that?
LinkedIn is the best way. I'm on LinkedIn, so hit me up there and let's start a conversation. We're all about making this a better place, not just for ourselves, but everyone that comes after us.
Absolutely, appreciate it. Well, you heard it from Katie. Thanks for watching, guys.